Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So today we're presenting a multidisciplinary national Delphi study that we both participated as authors in in conjunction with the emergency department at the Civic Hospital, as well as multidisciplinary teams from across the country with variable representations. The goal was to address a big topic that we all struggle with from time to time in family medicine, as well as in hospital, geriatrics, and other fields of medicine, which is the topic of opioids. As you know, opioids are a powerful tool that is a double-edged sword. It has the potential for benefit as well as the potential for risk. The majority of the patients, however, are prescribed opioids are typically prescribe them in the emergency department after an acute event, and those are our what we call opioid naive patients. The study aimed to identify a gap in the Canadian guideline for discharge instructions. Basically, at this point in time, prior to this study, we did not have any consensus regarding what information we should provide our patients. This helps in multiple ways. One, it provides clear, concise information to the patient. It highlights risks and benefits, and it addresses many of their concerns or questions. It also allows to establish expectations and help with the management from both primary care, emergency department, and other fields of medicine. The tool we utilized, or the study type, is the Delphi study, which is a well-established approach answering research questions through consensus. The origin comes from the Oracle of Delphi, and this study has been validated and well established since World War II, including in the U.S. military. The idea is we can come together and create consensus to allow us to move forward and identify high needs areas or provide recommendations. Currently, it's highly utilized in social studies as well as in the fields of medicine. Without further delay, we started the study by obtaining participants, and we had a large group of participants, including emergency department physicians, family doctors, pain specialists, nurse practitioners, a patient, and other allied healthcare partners. And the goal was to provide 19 initial concepts that are developed after review of the literature and meeting with the local experts. We've met and discussed such concepts at length, and we presented those kind of initial recommendations to our consensus group. And the goal was to identify the group opinion regarding which topics would be appropriate or high yield of high importance. So I'm going to step a little bit back and just go over a couple of the items we found. First of all, we found that the discharge instructions from the emergency department are often inadequate, and that leads to adverse outcomes. I know right now in the epic world of EMRs, patients receive a powerful tool called the after visit summary sometimes. It typically is printed with every discharge from the emergency department, the hospital, etc. This tool has been validated through multiple health medical records to provide the patient with a summary of their care as well as instruction about what to do home. We felt that this might be the location for such instructions, and this have been implemented in different types of electronic medical records, or can be photocopied and given as papers to the patient before they leave. The biggest question we asked is, what are the consensus concept that we should include about written opioid discharge from the emergency department? And we found that, one, they're essential. We reached consensus on 21 concepts, and I will show them a little bit later. We did not reach consensus on 2 specific concepts, and we'll also discuss those in a little bit later in the study. In general, I think this is one step to open the door toward further studies regarding engagement with our patients, with our colleagues, and creating expectations regarding the potential benefit and risks of opioids, as well as the safest way of using such powerful yet potentially harmful tools. These are quick kind of summary of some of the results we established. So we achieved 100% response rate in round 1. For those who are not familiar with the Delphi, I'm going to skip a couple of slides. We presented the original concepts in round 1, and basically whatever concept received consensus moved on to round 2. For those who didn't, we discussed at least in round 1, and then we reworded or addressed some of the concerns and moved toward round 2. And again, whatever is not agreed on, we rediscussed it in round 2 and provided another chance for the team to reach consensus. Those we agreed on moved on to the agreed concepts, and then those we didn't reached round 3. And unfortunately, there are 2 concepts that we did not. But in general, these are the concepts with the highest level of agreement in relation to minimizing use of prescribed opioids or mixing them with drugs, alcohol, and other risk factors. These are the concepts that we reached consensus on with the help of many of our colleagues. Some might sound very basic, but there are multiple studies suggesting that most opioid addiction starts in the emergency department. For example, there was a big study on ankle injuries that resulted in no fractures, but sprains, swelling, falls, and 15% of patients presented to the emergency department in such study were prescribed opioids. About 30% of those ended up developing lifelong addiction issues. So there are multiple studies in the literature suggesting that opioid naive patients with the wrong instructions may actually or inappropriate prescription may result in lifelong of suffering and adverse effects. So I'm going to go through them in detail, a little bit in step by step. So The first item is we should use the lowest possible dose for the shortest duration of time, and I think that's an important piece to add, and I think we all agree on it from primary care. Non-opioid medication should be first line. Do not combine it with alcohol. Keep them in a secure place away from children. Do not drive, operate heavy machinery. If there is other medication such as benzodiazepine, there is a risk of overdose. Do not share it with anybody. Opioid can impair decision making, and that might be increase the risk, for example, of fall, the elderly, or increased risk of drowning in water activities, etc. There is a significant risk of addiction and dependence. Part of it is genetic, part of it is habit and lifestyle. There is an expectation that another healthcare provider will need to reassess the need to continue these medication long-term. There are lots of non-pharmacological options to help reduce the pain, immobilization, relaxation techniques, etc. They are not intended to eliminate pain, but to decrease it to manageable level. Common and potential dangerous side effects of opioids were discussed, and those would include everything from constipation to itchiness to change in mood to swelling in lower extremities, respiratory distress, death, etc. If these opioid medication are not used, then bring them to the pharmacy. The sign and symptoms of toxicity to watch for were also an agreed on item to be provided to the patient. There were specific focus on constipation because it's the most common side effect. And then there are factors that patients should be aware of that may increase the risk of dependence. Those include, but not limited to, prior or current substance misuse, untreated psychiatric disorder. And there are others who have a higher risk of elevated risk, and those are polypharmacy patients or those with impaired renal and liver function. And then, the rest is discussion about what is an opioid, how do the medication work, and how can they be a safe and effective medication to treat pain or a tool, and under what conditions. These are the two concepts that we did not reach consensus agreement on. One, patients advise other individual they are living with or are taking opioid for pain and sign of symptom toxicity to watch for. Lots of discussion about this point, specifically regarding to patient privacy and patient wishes. Some felt that this is a decision left to the patient. Other felt that this may not apply for all. And the second one, to our dismay, is the naloxone kit. It is free in Ontario, and a good practice would probably consist of discussing it and prescribing it for anybody who's receiving opioids. Unfortunately, it's not free everywhere, and it's not really available across Canada, and depends on where you live and the province, and therefore these were the kind of the limitations to the naloxone kit. It doesn't make it a bad recommendation. It's at least in my personal opinion, it's probably a very powerful tool to have, and it can help highlight the risks of such medication, as well as create a safety net, especially as our healthcare system deal with ongoing stressors, to say the least. In terms of conclusion, we achieved consensus on the 21 concepts we discussed earlier, and we hope that this study will bring about a new era of kind of consensus and instructions, collaboration with patient and other providers with regards to opioids. We also recognize that there are strengths and limitations to the study, and it's likely will open up the door for further research into what patients would like to know and how can we deliver information effectively, as well as reduce the use of opioids if possible in the long term, and therefore reduce their side effects.
But over the past couple of months, our team at Bruyère has been working towards creating a dashboard to help improve patient access, particularly at the Bruyère Family Health Team. We're also looking to expand it further towards other specialties, allied healthcare, and maybe eventually across Ottawa. So to start off, I have no content to disclose. And so currently it is no particular surprise that over the past couple of years, due to COVID-19 and also various other issues, there's been an issue with primary care access, as patients are finding harder to access primary care, and also there's been an increase in wait time. At the Bruyère Family Health Team, we've been trying to assess this issue. However, there's some particular concerns for involving quality improvement. In particular, data. Although there is a lot of data on appointment availability, a lot of data on appointments, there's just too much data in a way that is difficult to see, in a way that is inaccessible to physicians and the team. Therefore, we were hoping to create a dashboard that's user-friendly and effective, so we are able to see this data more clearly and more usability. In addition, we want to have a dashboard that is easy to maintain and modify, so in the long term, in the future, we're able to keep it running continuously to see a long-term tracking of patient access. And in addition, we want to have it so it's more customizable for our clinic's needs. So why don't we use current dashboards? Well, current dashboards such as the I4Qs, they currently focus more on patient outcomes instead of patient access. And we wanted something that is more directly focused on wait time, patient care, supply and demand of physicians and appointments. In addition, some of these dashboards are not compatible with our specific EMR, which is PS Suite, and they can be costly. In addition, sometimes they can be user unfriendly and might not be specific to our family health care team needs. So how we started out actually creating this dashboard is through an indicator search. We want to have a large inventories of indicator that assess our patient access, supply, and demand. So some of you might have gotten an email from me or a phone call, as we've contacted Chaplain Region family health teams and other academic family health teams to understand what they're doing in order to assess their own personal patient access. And maybe they have their own dashboard that we can use in order to understand and create our own. Next, we found more indicators in government guidelines and systematic reviews in order to increase the volume of our list and create a large inventory that we can pick and choose from. So we actually had around 22, 25 different indicators. And the problem with that is that although it's great, that's too much. And some physicians might not find that as useful. So do administrators. So we narrowed down and we wanted to focus on indicators to specifically measure supply and demand indicators / modifiers. And through a small group of providers and administrators, we further narrowed down to what is the most effective for them and what do they want to see. And most importantly, to ensure long-term feasibility and reliability for our data collection process, we made sure that all of our data is compatible and extractable with the TELUS P-Suite appointment system. So after that, we narrowed down to a total of 8 indicators and 1 patient survey. And this is our dashboard. So as you can see right here, the dashboard, we wanted to have a more interactive and visually appealing dashboard. So by through this dashboard, you're able to choose a provider that you wish to see the data from. You're able to choose a time frame that you want to see your data. And at the same time, there are different indicators scattered across these 3 different tabs. So I'm going to start focusing on the individual indicators that we chose. So third next available is considered the gold standard for wait time in Ontario. And how it works is that you skip over your next available appointment, you skip over your second next available appointment, and you count your third ones. The reason why is because the first 2 appointments are usually caused by no-shows or cancellation, which doesn't accurately represent the wait time the patient have to observe in order to get their care. So by skipping to third next available, that more accurately measures the average lowest number of time periods that a patient will have to wait. And this has particularly been measured in the Bruyère Family Health Team. And by adding on here, providers have an easier way of seeing their wait times and just be able to measure it. Next, we have this next same-day appointment, which is more particular to the Bruyère Family Health Team, as we have same-day appointments embedded in our appointment system. Having these same-day appointments allow us to more effectively assess urgent care from our patients. However, a problem that's been occurring in our team is that some of these same-day appointments, instead of being used for urgent appointments, have been used for returns or follow-up, which decrease the ability for a patient to come in for urgent care. So we have it in here to also track that to make sure that patients are able to access urgent care. Next, we have visit numbers and resident appointment numbers, which also helps us assess what's the supply that we have in terms of appointment times and appointment slots that patient can book, and helps us assess the overall supply of care. So onto the visit description, and this is what we were hoping to use in order to address more inefficiencies or help improve the quality of patient access. So we have continuity of care, which essentially represents what % of patients are able to see their rostered provider. And research has shown that the higher continuity of care leads to a decrease in follow-up and a decrease in return rate, which overall in the end helps decrease our demand for care, and in the long term helps decrease the wait time for patient access. We are able to break it down further into a more detailed view. However, due to confidentiality issues, I'm not able to show this at the moment. However, if you're a Bruyère family physician health team, you'll be able to see this sooner in the future. Next, we have no social cancellation, which you all might know. Whenever a patient doesn't show up, you're still booking that slot. However, that slot doesn't get filled, and the patient might still need to come in for the future. So this causes a problem as the supply decreases since you're losing that slot. However, the demand does not. Therefore, in the long term, you're going to create a further backlog and increase the patient wait time. So this is important for us to track because we can know for sure now what we should focus on, how we should address. As you can see here, we have benchmarks as these orange dots that you can use in order to help better assess, hey, are you currently meeting the clinic's guidelines, meeting current clinic standards? And we're hoping to actually shape this benchmark more to fit our needs and to better fit our needs and how better fit what physician thinks should be included. Next two ones, I actually want to tell a story with return rate. So how we measure return rate is whether a patient comes back within either 4 days or 7 days after appointments. And a problem with this is that recently the government of Ontario changed their remuneration. So if you have a phone appointment and you want to move the patient in for an in-person appointment, you don't get the remuneration, you don't get an effective remuneration for that. And that causes you a decrease in compensation over your care. In addition, by having patient come in after another appointment, that increases our demand, and overall that can increase wait time in the long term. So we have been talking, a lot of physicians and administrators have been talking at Bruyère Family Health Team saying that phone appointments may lead to an increase in in-person appointments or just overall just appointment time. We didn't have the data to address this, and now we do. By having this dashboard, we can see here that almost over time, over 50% of the appointments that came from almost 50% time of the returns that came from appointments were from phone appointments. And this is important for us because now that we know that we have increased returns from phone appointments, we can effectively create better algorithm in order to address this. Maybe how can we better have it so we don't need a phone appointments and we can just bring the person in person right away, because we know for sure we're gonna have to do a physical exam for them anyway. Or how do we better make it so a phone appointment is more effectively solves their concerns? And so we don't need to bring them in person. So this return rate overall here can help us decrease the wait time in the long term by just decreasing the demand for care. And next, we have the type of appointments. So this is important here for providers at Bruyère, as we just want to make sure that we meet the government standards of 60% having in-person appointments. And next, we just have the patient survey. So currently, right now, we're using the Chaplain Region Family Health Team Survey. the Chaplain Region Family Health Team surveys in order to assess our patient satisfaction with care and what they feel about their access. In the future, we're actually hoping to decrease it to a more often basis. So once a month, patients will be able to receive a survey to assess their care and assess their wait times. Through this process, we can see, hey, are our wait times worse for patient at certain months and how we can better improve it for them. So the next step in this process is for us to share all providers at the Bruyère Family Health Team. So if you're part of Family Health Team, we just been going through security and trying to working out some logistics regarding that aspect. However, soon we'll be sharing it with everyone in order to help them use it and see if it's one, is it usable for them? Are they able to use this dashboard in order to make changes to their own practice? Two, is it effective for them? Are they able to look at this dashboard and understand what they should be doing? Then we want to actually track this process in long term. Over a long period of time, with the use of this dashboard and the information that's provided through it, is patient access going to be improved, and by how much and how so? In addition, we were hoping to have being more scalable to allied healthcare team members and other needs such as patient outcomes. And the most important aspect is just continued modification. So as new guidelines are added and new indicators are added, we can continually modify to support the patient provider needs. So we're hoping to have further application for this. So not only could this be used for family medicine, I believe strongly that could be used for other specialties as well. By having increased access to data and information for everyone, you can decrease wait time, not just for family medicine, but also for surgical care, for specialists, and overall just helping see how we can better quality improve our processes. Next, it can be help improve clinic management and also other QI needs. So not only patient access, patient outcomes, patient care, patient satisfaction, to see overall how we can better quality improve our processes. So that's the end of my presentation. If you have any questions at all, you can feel free to contact my email at jla@bruyere.org. And yeah, I'm open for questions.